I'm taping this fairly late, so don't be surprised if I make some stupid puns or stupid jokes. All right, so antimicrobials also include things like fungi. I'm kind of a fun guy. That was the first bad one. Um, Fungal infections, when do we get them? Well, when other bacteria are killed. So if you've got somebody that's on a lot of antibiotics, sometimes they'll get a fungal infection. Classic example is a woman that is on antibiotics for a sore throat. We kill off all the bacteria in her vaginal area, and she develops a yeast infection. Yeast is a type of fungus, of course. Um, you can get fungal infections elsewhere if you're on antibiotics. Intertriginous spots. Those are basically the folds of your arms, legs, abdomen. Fungal infections like to occur any place where it's warm, dark, and moist. So in the groin area, on the feet, they will occur in those areas even when there isn't antibiotics or anything unusual. Sometimes people have ineffective lymphocytes. The most common example of this is people with HIV. People with HIV will sometimes lose their CD4 lymphocytes, and unfortunately, that puts them at risk for protozoal, also known as parasite, fungal, and certain type of viral infections. So when we're talking about fungi, what are we really talking about? Well, there's tens of thousands of species of fungi, but there's really only about 150 to 300 that will actually cause problems for humans. Most common one we see is Candida. This is, a common yeast. The most common one of those is albicans, but glabrata, and there's probably a lot of others that are currently causing infection problems. This may be an issue because as some of the Candida species become more resistant, some of the others grow in. Aspergillus is another type of fungal infection. Maybe way more common than we think. A lot of patients who have allergies, if you put an antifungal on their skin, they get better. This may be because Aspergillus and some other fungi are on their skin and are creating an allergic type response. So one of the theories of eczema is that it's really a fungal type infection. Cryptococcus is a type of infection that will happen mostly in HIV patients. Blastomyces also is a fungal infection, although not very common. Histoplasmosis, most common in places where people are exposed to bat guano, so they call it spelunker's disease, people that go down in caves. We also sometimes see it in people that have pet birds or around a lot of bird droppings. I had a patient a number of years ago that was cleaning out a church steeple, and there was all sorts of pigeon droppings, and he developed histoplasmosis and had to be on antifungal medications for a very long time. Dermatophytes are a type of fungus, happen a lot on the feet, often related to those thick, disgusting toenails that people get. Pneumocystis, what used to be called Carini, now Girovecchi, is another type, again, often related to people who are immunosuppressed, especially HIV patients. Stichybotrytis chartarum, which is black mold, is probably way more problematic than we've previously thought. Obviously not going to spend a lot of time talking about that here because we really don't have a whole lot of pharmacology approaches to it. But it is something that I do think that as a society we're going to have to look at more closely because especially people in older housing and a lot of rental housing are often exposed to black mold. So don't spend a lot of time really thinking about these classifications. I've mostly thrown them up here as something you can be familiar with, but also to make the point that there are separate classifications of antifungals. and that you may need to use a different type of family to get to a different type of solution. Membrane disrupting agents, amphotericin is given IV. Nystatin is given topically very often. Nystatin was actually developed in the New York State labs in Coxsackie, New York, where also the Coxsackie viruses were discovered, hence the name Nystatin. Those two are actually polyenes. Polyenes are one type of antifungal. The polyenes seem to not be quite as effective against Candida as they previously were. So we have moved usually to other types, although especially in babies and some other folks, Nystatin is still an appropriate choice. The ergosterol synthesis inhibitors, predominantly the azoles and the allylamines, are the two types of families that you're going to be most interested in. They basically do the same thing, although they do work slightly differently, so that you will sometimes want to use one versus the other. Flucytosine is a medication that's only used in combination with another antifungal for severe infections. Griseofulvin is an oral antifungal that's used for a number of things, but especially for tinea capitis. Tinea capitis, which is a fungal infection in the hair, is actually very difficult to treat and cannot be treated or cured with topical antibiotics. There really isn't a shampoo or anything that's effective. So people with tinea capitis do need to go on an oral antibiotic. Griseofulvin is the most common one, and it basically is almost like a chemotherapy type agent because it breaks down the ability for the fungi to reproduce by blocking the mitosis. The echinocandins are newer. They interfere with cell wall synthesis. I think we'll probably be hearing more of them as time goes on, but they're not particularly commonly used at this point. A chitin synthesis inhibitor, Neomycin, is pretty rare. They are looking at it maybe for valley fever, which is a valley out in Arizona that gets an outbreak of coccidiomycosis every year, but it is not commonly used. And the sordarins or the azosordarins are also not particularly common, but this slide is just there to make the point that there are other families and that we may be seeing other things coming down the pike. So the azoles are a very common type of antifungal that you see. Chlorotrimazole is Lotrimin. That's a sort of prototype. They should hit most candidas, although not all. They'll hit a lot of the other types of fungi, but mostly they're used topically. So you would not use Lotrimin for these kinds of things. Another azole that you might use for these kinds of things would be diflucan. So the allylamines, Lamisil, which is used both topically and orally, is an allylamine. Less effective for candida. So people that use Lamisil for jock itch or athlete's foot, it's going to work great if it's not a candidal origin, if it's a dermatophyte origin, but you may need to switch it around if it's not working. The other way also is true. If you've got something that has great candidal coverage but is not covering the dermatophytes, you may need to switch it around so that you can get something that covers. The thiocarbamates are in those same family with the allylamines. Again, though, the tolnaftite, which is tufactin, tinactin, is another option. I use this a lot in teenagers because it's sprayable, and they far prefer the spray to greasy and gooey ointments and creams. So this does give you another option. Again, you do sometimes just have to rotate your choices. So that sort of concludes our discussion of the fungi. Mycobacteria are actually somewhere in between a bacteria and a fungus. They have a much thicker cell wall than almost any other bacteria, almost as thick as most fungi. The mycobacteria are extremely difficult to kill. Fortunately, they're pretty rare in 21st century America. Other parts of the world, they still see a lot of tuberculosis and other mycobacterial type infections. Another mycobacterial infection that we did see a lot in the early days of HIV was Mycobacterium avium. Sometimes they called it complex, sometimes they called it intracellulare. But that is an infection that does respond pretty well to the mycobacterial type drugs, although again may need a more aggressive approach. So when do we do antivirals? Well, antivirals are pretty effective at killing the virus. The challenge, of course, is that sometimes they can also harm the body. Fortunately, the newer antivirals that we've developed are better at getting rid of the virus without causing side effects. Most of the antivirals are actually pretty harmless. The thing, though, is that the majority of viral infections are self-limiting, and that the potential side effects of the medication would probably be greater than the potential benefit for using it for treating the virus. So we don't use them on all viruses, but in a lot of viruses that have the potential to spread and be persistent, we definitely have some options now. So what viruses would that be? Well, herpes simplex is a viral infection that we commonly use. Medication, the acyclovir or valcyclovir are very commonly used for this. Valcyclovir is basically 2,000 milligrams once and then repeated again in 12 hours and then you're done. The majority of patients, this will really clear up their herpes simplex infections if it's type 1, right? So herpes simplex type 2, which is genital herpes, obviously would require a more prolonged case of treatment. We'll talk about each of these on a separate slide. Okay, so here's the daily double. What's the treatment for zoster? So first of all, this is a trick question. Some of you may want to pause the presentation right now and look it up in the Stanford Guide. I would heartily encourage you to do that. If you've done that and you're now back, the first thing is don't forget that zoster can be either varicella zoster or herpes zoster. Varicella zoster is chickenpox, and so the treatment for chickenpox does include antivirals, things like acyclovir and valcyclovir, and herpes zoster, same thing. The other question with herpes zoster is, do you add a prednisone steroid type medicine to decrease the pain? It doesn't seem to decrease the risk of postherpetic neuralgia, but it will help decrease the pain at the time. We'll have a discussion about pain control somewhere down the road, but we'll leave that for then. Influenza. So influenza is a virus. It is a virus that occurs usually seasonally. I tell people when they see the pumpkins, start thinking about getting your flu shot. Influenza is a potentially deadly virus. Doesn't kill too many people, but it definitely kills some people every year. The potential benefit of the vaccine, I think, is substantial. I would heartily encourage you to look up the NNTs and NNHs on the vaccine, and we'll probably discuss those in class. And we'll also talk about the various treatments if you want to. Tamiflu is the most common one, 75 milligrams of Tamiflu twice a day for 5 days. For prevention of the flu, it's 75 milligrams once a day for 10 days. Relenza is another influenza type medicine. It's actually inhaled. It's hard to give. Almost always we reserve this in case there is a shortage of the Tamiflu. The amantadine was a medication that we used years ago. We're actually using it for Parkinson's disease, and we serendipitously found that some of those people got benefit for their viruses. It really is only one of the two types of flu, A versus B, and it rarely is used for influenza now. HIV. So a little discussion about HIV here. So how do we treat HIV? Well, basically, the treatment includes 3 drugs, usually 2 antiretrovirals and a reverse transcriptase inhibitor. Sometimes there's some variation now. There's a lot of combination drugs out there. There is a medication that is used to prevent HIV, right? We call that PrEP, for pre-exposure prophylaxis, and that medication is called Truvada. Truvada is a very effective medication. It contains 2 medications, tenofovir and emtricitabine, which are emtricitabine, that are used in combination and do seem to substantially decrease the risk of becoming HIV positive. So pretty much everybody in the world knows how you get HIV now: exposure to blood and body fluids. Most common way is still men that have sex with men. This is not, of course, just gay men. There are heterosexual men that are raped in prison. There are a lot of bisexual men. So it is the still most common. There is more heterosexual transmission. Women are having more HIV, although that incidence has pretty much stabilized. IV drug users are still getting HIV, although many of them overdose and die before it seems to be an issue. Splashes in a work environment. There's a small number of healthcare workers each year that do get HIV from needle sticks, but it is a very small number. There are also babies that have it passed, although with the current medications, that's much less common. So pretty much the majority of you were not born when HIV and AIDS were still being identified. Some of us were, but none of us were all that old. In 1981, there were 6 cases of pneumocystis carinii pneumonia and 26 cases of Kaposi sarcoma, almost all in gay men. Initially, they called this GRID, for gay-related immune deficiency. They had no idea what was causing it. Poppers were amyl nitrate, and a lot of gay men were using this to accentuate their sexual experience. They thought it might be related to this, but they did identify as they went along that it was a virus, and they actually isolated and named the virus in 1984. So currently there's about 37 million people in the United States with HIV and AIDS. About 67% of these people are in Africa, which represents about 4% of the population of Africa. It's about 500,000 people in the US that are diagnosed, maybe a lot of others that are undiagnosed, but we definitely have provided pretty good control for many of those folks. 37 million is almost the population of California. California is just slightly more than that. It's been growing. And it's just a little bit more than the population of Maine, New Hampshire, Vermont, Massachusetts, Connecticut, Rhode Island, and New York combined. So when you have somebody with HIV, or when it has progressed, when they get an opportunistic infection or their CD4 count goes low enough, they're actually redefined as having AIDS. those people get various types of infections. Again, pretty rare now that we have good medication management, but they can get PCP, the pneumocystis carinii pneumonia, more commonly called PJP or pneumocystis jirovecii pneumonia, toxoplasmosis, which is a protozoal infection. We hear a lot about toxo in regards to pregnant women. The problem with toxo is it's really a pretty benign condition where somebody just feels a little lousy, gets a little bit of a sore throat, and feels like they have kind of a mild viral infection. So, there's probably a lot of people that get toxo every year. It is potentially teratogenic, and this is why we don't want pregnant women getting it, with the cat litter and all that kind of stuff. So, people with HIV do get tuberculosis, again, more in Africa than here. Kaposi sarcoma has been associated with a virus, the human herpes virus number 8, which we'll talk more about human herpes viruses as we go on. Everybody thinks of them as the herpes simplex and the herpes zoster, but there's also a human herpes virus which causes a common childhood rash and fever. I'll let you look that one up. So, and then MAI, MAC, Cryptosporidium, which is a parasite, AIDS, dementia, yeast infections, CMV, retinitis, cytomegalovirus is a virus that can cause substantial problems in the retina if someone doesn't have the ability to fight it off. Lymphoma is probably a cancer that is related to certain viral infections, and cervical cancer, which of course is related to HPV in almost all cases. So why do these people get it? Well, they don't have an effective immune system. A retrovirus has gotten into their cells. That retrovirus often attacks the cells that are CD4. It basically starts writing their RNA backwards. It then explodes, and then the RNA is transposed into other cells, and it occurs over and over again. Again, predominantly these CD4 cells. The problem is that the organism then does not have the ability to fight off infection and can develop these substantial infections and die. So it's these T lymphocytes, the CD4 type. Those usually fight off protozoal, fungal, and certain viral threats. And so if you have this, you can't fight them off. We can test for antibodies to the virus. That's been the most common way to test for HIV, and still is. The issue with that is that there is a 6 to 12 week window period in which the body takes time to build up the antibodies enough to be tested. There is, however, an ability to actually test the actual viral load. You have to remember, though, that even in people that are treated for HIV, the load is never reported as 0. It's always reported as undetectable. Just because 0 would infer that there wasn't anything there, undetectable means that we're pretty sure that in people that are already infected that there's still some virus there. We've just got it under such good control that we can't find any of it. So parasites, protozoa are the most common type of parasites. Parasites are just another way of saying a cell membrane or in the animal kingdom. Worms and mites are also technically parasites. HIV patients do get all of these, but we do want to discuss parasites that occur even in people that are not immunosuppressed. So other people that can get a parasitic infection or a protozoal infection are people who drink bad water. Amoebic dysentery, which is a infection that gets into the gut and causes substantial diarrhea, is definitely a problem around the world. My nephew just got back from India. He's having substantial diarrhea. One of the possibilities that he picked up Giardia or amoebic dysentery. It's less likely, though. It's more likely that he picked up some other type of viral or bacterial infection that's causing his diarrhea. About 7% of people coming back from India will have either Giardia or amoeba. So we could give him some antimicrobials with antiparasitic effects. Since it's only about a 7% chance and that the vast majority of the infectious causes are bacterial, which respond to fluoroquinolones, I think we're better off to do a fluoroquinolone if we're going to do an empiric type treatment. Empiric means based on previous research. We don't really have time to test him to get all of the answers with any sort of certainty. My brother actually had some Flagyl. He said, should I go ahead and give him the Flagyl? I'm saying, no, you really probably shouldn't. Maybe some Cipro or some Levaquin would be just fine, at least as an initial treatment. And the Sanford Guide actually does recommend doing this empirically in people with diarrhea, and we'll talk about that in a minute. Other antimicrobials that have antiparasitic effects, mebendazole and albendazole also cover for worms. Ivermectin also covers for scabies and somewhat for worms. The problem with mebendazole and albendazole is that the wholesale cost of these is about 40 cents a pill. Amidra is a company that just bought up both mebendazole and albendazole here in the United States. Thus, they basically have a monopoly, and they have raised the costs, which wholesale was about 40 cents, retail was about $4 a pill. They've now raised it to about $440 a pill. This is what you get when you have an unregulated market, I guess. So at any rate, if you have somebody that has worms or other types of mites, these others are an option. Rifampin and amphotericin also have some antifungal effect usually, tend to be a lot more aggressive. You'll see those used intravenously, especially those of you that do acute care. Treatment for Giardia, again, I'll give you the chance to go ahead and look that up in Sanford. I actually did not look it up this time. I always use Flagyl. I usually look it up each time, and we'll talk some more in class about treatment of Giardia. So other types of bacterial diarrhea. Note that the majority of these types of diarrhea are either bloody or they respond to Cipro. So if you've got somebody that's having bloody diarrhea, then you do need to do some more evaluation and possibly cover them for something that will cover for a bloody diarrhea. If you've got somebody that just has a basic diarrhea, they're having 6 or more stools a day, they have a bit of a fever to go with it, the Sanford Guide says that you can empirically go ahead and start them on Cipro 500 for 3 to 5 days, BID, and that then if they're not cured, then you can go back and you can do stool cultures, stool for white blood cells, those kinds of things. We'll talk more about that workup in the labs and diagnostics course. Another types of diarrhea would be rotavirus and Norwalk virus. Norwalk is just going to have to run its course. Rotavirus can be prevented by a vaccine. We only give it in babies less than a year old, but basically these viral diarrhea need supportive treatment. Imodium, those kinds of things actually might be effective. I would not use Imodium in someone unless you've ruled out a bacterial diarrhea, just because that patient could end up with a bacteremia. But in people with viral diarrhea, sometimes an Imodium can be helpful, but that you're going to hydrate them and keep them symptomatically and systemically healthy. So cancer patients also have greater risk for protozoal infections, and we've already talked about that. Mites like scabies, I think that you will definitely see a lot of cases of scabies. The most common treatment is elamite, which is permethrin, which is put on from the neck down overnight and then washed off in the morning. Patients need to be warned that they will continue to have itching and symptoms for at least a week or so after. You can repeat the treatment in a couple of weeks if you think that there's any residual mites, but you also need to pay attention to clothing and bedding. Swimmer's itch. Swimmer's itch is something that you will definitely see usually in the fall in places where there's lakes and there's a lot of ducks swimming around in them. They also call that duck itch. The ducks ingest it. It goes down into the clams that are living in the freshwater clams, and then they release schistosomes into the water. Now, this concerns some people because schistosomiasis is a disease in Africa which causes blindness and is an extremely serious condition. These schistosomes are completely benign. They cause inflammation of the skin. It can last a week or so, but symptomatic treatment, if it's really bad, you can decrease the itch with prednisone, but usually just a topical treatment and reassurance is enough for them. Immunizations. So I would like to talk a fair amount about immunizations in class. I think people will have a lot of interest in it. But before we get to immunizations, let's talk about passive immunity. So in people that don't have immunity to a condition, if they're exposed to it, you can't just give them, an immunization because that will then provide benefit a year or two down the road. You need to give them something that is actually going to protect them today. And so immune globulins, the most common one we see is rabies immune globulin. If you have someone that's bit by an animal that we think is rabid, you'll actually infiltrate some right into the area where the bite is, give the other half IM, and then we will also start the rabies vaccine at the same time. Hepatitis B has an immune globulin. Varicella zoster has an immune globulin. An example of that would be is if you had a pregnant woman that was exposed to someone with chickenpox, and the pregnant woman has not shown immunity to chickenpox, you could actually give her a dose of VZIG. So if those are passive immunity, what's active immunity? Well, active immunity is when you give a regular vaccine. Someone who doesn't vaccinate will sometimes actually expose their child to chickenpox and let them get chickenpox. They're basically immunizing their child against chickenpox. When we give it through shots, we usually refer to those as vaccines, and we talk about vaccinating. So the rotavirus is a common vaccine given at 2, 4, and 6 months. It's to prevent diarrhea. Diarrhea is a common and sometimes still significant problem for babies. The doctor that helped develop this virus is a Dr. Offit. The problem is that a lot of the anti-vax people call him Dr. Profit because they say he is benefiting from these vaccines. He is, in fact, getting a financial benefit. Whether this affects his professional opinion, I can't tell you, but they're very concerned. I do look forward to discussing the vaccines with you all in class. DPT is a common vaccine, diphtheria, pertussis, and tetanus. It is different from the Tdap because the Tdap has less diphtheria and less pertussis in it. That's why the letters are smaller in Tdap than they are in DPT. Tdap is usually given at 12 years old and above, although if someone is doing a catch-up vaccine, you can give it a bit earlier than this. MMR, measles, mumps, rubella, those are all viruses. Hib is a bacteria. Hib used to be a relatively common cause of ear infections and meningitis, but the Haemophilus influenza type B is rarely a cause of these now. The polio vaccine we give all injectable now. The oral polio vaccine did seem to have about 10 cases of polio associated with it in the United States each year, so they did decide to switch it to the IPV. The PCV, or the pneumococcal conjugate vaccine, also known as Prevnar. Conjugate vaccines are actually better than polysaccharide vaccines. That's why we use the Prevnar in adults now, as well as doing the polysaccharide vaccine. Hepatitis A and hepatitis B are usually done in children. Hepatitis B is a sexually transmitted infection, and we do want to see if we can prevent that. Hepatitis A is foodborne. Some pediatricians do not give this. This is usually not required for school. I tend to try to get kids to do it if there's any chance that they'll do any international travel, just because hepatitis A is a good vaccine to have had if you're going to do any international travel. Varicella zoster vaccine needs 2 shots. Definitely review the immunization schedules from the CDC and from the state before you go into your pediatric rotations. HPV, or the Gardasil vaccine, is given in age 9 through 26. It definitely is associated with cervical cancer. We're now seeing more and more cases of head and neck cancer that are associated with HPV. The last 4 patients that I've had, the last 4 men, they have tested these head and neck cancers to see if they're HPV related, and they all were. I do think the Gardasil has real potential. The problem with the Gardasil is that we don't have more than about 15 years of experience, so we're not exactly sure how it's going to work 25, 30 years down the road, but the potential benefits are substantial. When it first came out about 15 or 16 years ago, there were a couple of cases of Lou Gehrig's disease that seemed to be associated with the HPV. We've given 60 million doses of the HPV since then, haven't seen any other cases. Not sure if that was just a coincidence or whether there was a bad batch there, but at any rate, it does not seem to be currently an issue. Meningitis is a infection of the meninges, the Dura-the-Pia and the Santa Maria, the arachnoid. Anytime those are inflamed or infected, you get really bad headaches, really stiff neck. The most serious cause of that is a bacteria called Neisseria meningitidis. There are other things that can cause meningitis, such as viruses, Hib, if someone's not immunized or if the immunization wasn't effective, pneumococcus, so that's why the Prevnar seems to be decreasing the risk of meningitis as well. But Neisseria meningitidis, there's about 6 strains of Neisseria meningitidis that have been known to cause meningitis. A, B, C, X, Y, and W135. 4 of these were relatively common in the United States when the vaccines were developed 10 or 15 years ago. That's why we have a quadrivalent vaccine, Menactra, or Menveo, also known as MCV4, which have the meningococcus in it. Those have A, C, X, and W135. Y is very rare in the United States. B used to be rare, but seems to be increasing in frequency. Thus, we now have a meningitis B vaccine. If you look at the actual data, there's only about 10 people in the teenage years that die each year from this. It's not a very large number out of the 300+ million people in the United States. But there is a vaccine now, and a lot of parents encourage their kids to get it. It is on the recommended list for Maine, so they will actually pay for it now. Another vaccine that, of course, you'll want to give children is the influenza vaccine. The nasal vaccine really doesn't seem to be effective at this point, so you really do need to do the injection. And in the small children, they do need the 2 injections. Shingles vaccine. Now, shingles vaccine used to be Zostavax, and Zostavax was modestly effective. Now it's Shingrix. Shingrix is a bit more effective. It is now 2 doses instead of 1. It does have a lot more side effects. My wife just got it and felt lousy for about 4 days after. It's about $150 to $175 a dose. But it does have some benefit, and there's a lot of elderly people, especially that are scared to death of getting shingles, and it will decrease the incidence some. Again, we'll try to review some of those charts and some of the actual data in class to talk about exactly how much it reduces the incidence of shingles. And then the adult vaccines. So when you turn 65 and you go to your Welcome to Medicare visit, they usually will give you a Prevnar. The Pneumovax has to be at least 6 months apart, but Medicare won't pay for it until it's at least a year apart. So at the 66-year-old visit, we'll give the Pneumovax. Tdap is not covered by Medicare. So unless somebody has a supplemental insurance, we usually don't do the Tdap unless they ask us to. It's about an $80 shot. Shingles is also not covered by Medicare A or B. The D programs are variable in what they cover, and I should have said that Tdap is sometimes covered by a Medicare D program, but there's a lot of different carriers for Medicare D, so people have to look into their individual programs. Hepatitis A and hepatitis B, again, we would rarely do this. They do recommend hepatitis B for diabetics. Most diabetics really don't have that much more risk than the average person, though. And then travel vaccines are available. If you have someone that's going to travel, you can go to the CDC website, see what's recommended for vaccines. And there are also travel clinics around that you can refer people to. Obviously, the more that you can do in your own office, the better. There's no sense of going to a travel clinic and then being told, yep, you're all set, and have that additional cost. So I think this covers a lot of the information. Again, we'll try to talk about things in class. If you have other comments that you would like to make, or if you're not actually part of this class, please feel free to post questions and comments on this video. Alrighty, thank you.